Good afternoon, friends. Thank you, Raman, for honoring me to deliver the Ajita Mehta oration. I'm really sorry for health reasons. I can't be there in person. But just a few lines on Dr. Ajita Mehta. She was fiercely independent, very dynamic, courageous beyond measure. In fact, there were times when she would get discharged from the ICU and come straight to the micro department. She was generous to a fault and a visionary who understood the importance of infection control. In fact, along with Dr. Shaheen Mehta, Geeta Mehta, she set up the HISI in Hinduja in 1992. We miss her warmth and affection. And today, coincidentally, is her death anniversary, her 15th death anniversary on the 6th of Feb. And to honor her memory, I'm speaking on the role of the microbiology lab in infection control. So I'm going to, this is my outline. I promised not to delay you or to be between you and lunch. But this is my outline of my talk. And I think basically it's a theragnostic approach with an integrated stewardship model of infection prevention, antibiotic stewardship, and diagnostic stewardship. Diagnostic stewardship really is what the microbiology offers. And the microbiology lab, as you know, has analytical, and post. And these points are well known to all of us that we need a good sample, but most important, we need a short turnaround time. Now, the three most important samples that we get in our labs are blood cultures. And if we look at diagnostic stewardship for blood cultures, which are the most commonly ordered microbiology tests, we need to focus on high and low diagnostic value for both initial and repeat cultures. For example, I think the time has come when there are infections with low risk of bacteremia, such as cystitis, prostatitis, cellulitis, and there is a low diagnostic value, when we shouldn't waste money and resources doing blood cultures in such situations. But for sepsis, endovascular infections, certainly. And similarly, for repeat blood cultures, I think we need to repeat Staph aureus, we need to repeat Staph lugdunensis and Candida. When you look at urine cultures, I think the time has come when we need to put our foot down that say asymptomatic bacteriuria should only be considered for treatment in two situations, that is pregnancy and prior to invasive urological procedures. And respiratory samples, I think we do a lot of issues here, with a lot of issues here, and we need to rethink pan culture. The impact of respiratory culturing on patients with low pretest probability of VAP needs to be considered. The second point is antibiotic, where the microbiology lab plays a role, is antibiotic policy updates for empiric therapy. Now, we all know initial empiric therapy is based on the antibiotic policy, which is really the basic, with the local resistance patterns for most likely pathogens at site. When a clinician makes a decision for empiric therapy, he looks at integration of likelihood of infection, local epidemiology of pathogens, screening data, and what tests he has at hand. And we from the lab need to generate institutional and unit-specific antibiograms. But I think most important is we should not lump together our AMR, because local AMR epidemiology is dependent on much, much more than just what we've stated before. It depends on patient's risk factors, site of infection, location in the hospital, and whether the patient has come from the community or has been there in the hospital. Now, we in our hospital for the last 10 years have started doing this. We do a risk stratified antibiotic policy where we have patient type 1, 2, and 3. And we found that when we did a risk stratified stratification, patient risk factor stratification, we could really give better pathogens. For example, a patient who has a bloodstream infection in the ward would have a organism Salmonella, and the one who would have a community-acquired infection in the ICU would have a strep pneumoniae. With this, we found that there was much, much better compliance to the hospital antibiotic policy. And with this as well, we found that, say, in the intensive care unit, for a community-acquired patient who came with type 1, the CRE risk was, isolation was nil, whereas in type 3, it was 39%. And today, one of my girls is presenting a paper on this, and you can ask her questions. The second is support diagnostic stewardship with rapid testing. Really, advances in microlab have a profound impact on infection prevention control, and that's where we start our targeted therapy with the rapid diagnostics. Unfortunately, diagnostic spend in developing countries has been as low as 6%, and we need to up the ante on this. Point of care diagnostics is really urgently needed, and a microbiology lab can right the ship for targeted therapy by essential, achievable, and aspirational goals. For example, you actively participate in the stewardship committee, you develop alert systems, you collaborate with ID physicians. Aspirational is perhaps looking at a national and regional surveillance system. So going back to what tests and when, rapid diagnostic tests really offer time to shorten the therapy and reduce mortality and LOS and length of stay. So how does rapid diagnosis, it may help the patient, but how does this essentially spay on to infection control? It really leads to earlier isolation and environmental cleaning intervention. If you can rapidly diagnose a patient, what he has and what his MDR is, you can institute early isolation and environmental cleaning. And today we have culture methods, you have MALDI-TOF, you have lateral flow assays that are really cost effective and cheap. Now, for example, even the LFA that detects 5 major carbapenems just costs about 600 rupees. And knowing the type of the carbapenems really dictates specific treatment. For example, our epidemiology is completely different from that of the West. We don't have much of KPC. Our bugs are OXA48 and NDM. And every hospital should keep this as surveillance ready for any clinician who wants to know. Molecular tests, again, targeted single resistant gene detection is so much faster. And today we have syndromic panels and preventing transmission, especially with respiratory and GI disease, and targets for appropriate pathogens. We have clear algorithms and guidelines are required. The fourth is HIA surveillance and AMR surveillance. They say you can't manage what you can't measure. And this is a sterling attempt at unifying our country and getting HAI surveillance networks initiated by AIMS Trauma Center, ICMR, and we're finally moving from tertiary care hospital to PHCs. This was recently published in the Lancet, and Purva has been outstanding in this, that she's really gone the whole mile to get this across India, these various sites. But at individual local hospital levels, we need to do surveillance as well. And these are our HAI rates that are shared monthly with all the directors for further dissemination to the healthcare workers. Now, learning from each other. I acknowledge the CDC team and the AIMS Trauma Center. Somewhere in the time of COVID, we certainly found we had an increase in the BSI rates in our COVID ICU. So we did a root cause analysis, we did a fishbone, and I'm not going to go through this again because you can refer to the poster by Julia. But we found that there was a corrective and preventive action possible only because we had surveillance in place. We had primary drivers, secondary drivers, we had the 5 Ys, etc. And look at this goes on, and you can actually look at the reasons that generate information from the 5Y technique and put corrective action and preventive action into place. Now, the next surveillance is AMR, the resistance movement, with CRE is on the move, carbapenem here today, there tomorrow. And this worrisome trend of plasmid-mediated spread of carbapenemas is really a big, huge issue. Anyway, the whole genome sequencing is a global transition from phenotypic to genotypic. And would a hub and spoke model help? Because overcoming the routine implementation of whole genome sequence in low middle income countries is formidable. Okay. Now, just to show you a small increase in Acinetobacter species in our hospital from October a year ago, when we suddenly found from 1 to 4, we jumped up to 8. By doing whole genome sequencing, we could convince our healthcare workers that the strains were identical and there was a lapse in infection prevention control. The fifth is rapid communication for MDRO and initiating isolation. Using colonization to assess the burden across low and middle income countries, carbapenem resistance is carried on fecal carriage. We published this among healthy individuals in India was about 6.1%. And this is a shocking study that we just finished with the Pune individuals, two Pune centers, where we found that 50% of patients admitted to ICUs were colonized with CRE. So we need to have a screening on admission policy for MRSA and CRE. We have a strict contact isolation where we look at the curtains to assess and look so that the doctors know that strict contact isolation must be followed for these patients. And even for patients who are not deemed to be treated, IPC needs to be initiated so that the colonizing organisms do not spread. Finally, there's outbreak detection. And this is what many years ago, I think this was in 1994, when we had, we were the first possibly in India to get this laparoscopic infection with Mycobacterium chelonis. 33 patients presented over 4 months with port site infections after laparoscopic surgery. We found that the AFB were positive from the smear, the TOCA cannula, 2% the glutaraldehyde soap tray, and the likely source was tap water. This is a rampant outbreak in our country, and I think every infection control person needs to be aware of this, because at that stage we could reculture from the soap trays of glutaraldehyde, Mycobacterium chelonis, that had a really high MIC to glutaraldehyde. Since then, we have strict infection control practices in place. We no longer use high-level disinfection. We only go for sterilization. We autoclave all reusable metal instruments, and plasma sterilization is done, or ETO gas sterilization, for something that is not autoclavable. And just to show you the repertoire of non-tuberculous mycobacteria, look at this shocking. This was patient from elsewhere. These are all referred patients to us, whether it's post-laparoscopy, whether it's post-angioplasty endarteritis, whether it is a DJ stent or a person who went to look more handsome, and look what happened to him. Today, we are seeing this as a huge outbreak in our country because of improper sterilization, because of the sterilization is not up to the mark. And these then get embedded in the patient. And we're seeing it in herniorrhaphy, breast implantation, even post-LSCS. And post-angioplasty stent infections are becoming a fatal situation. Finally, friends, facilitating good infection control practices is what the microbiologist does. He assists the physician in diagnosis of empiric treatment, aids in interpretation of results, avoids an unnecessary testing, and this all I looked at the program and found all these are going to be discussed. But remember that even environmental, all in-hospital construction or renovation should be signed off by the microbiologist. Airborne particulate counts in high-risk areas, water testing, feedback, and on SSI and needle stick injury. Now, if you see this, these were Dr. Ajita Mehta's initiatives. She actually started needle stick injuries way back in our hospital from 1996 onward. And just to show the various interventions, and our needle stick injuries have drastically reduced. So this is my last slide. And this basically talks on focused, updated knowledge, what the microbiologist does in prevention and management, ensures continuous digital microbiology support, face-to-face when advice is needed, 24/7 availability for rapid diagnostic tests and the interpretation, regular meetings, trainings, and updates. And finally, remember, hand hygiene is the basic tenet of infection prevention control. In 1990, more than 25 years ago, at a time when hand hygiene was its infancy and there were no ready-made dispensers available, Dr. Ajita Mehta set up dispensers that had ethyl alcohol with chlorhexidine at every bedside in Hinduja hospital. Today, that was her legacy. Thank you.